প্রোগ্রাম কি স্টার্ট হয়েছে? Assalamu alaikum and very good evening. We are going to start our today's session, a very interesting session on granulomatous lung disease. It will be presented by Dr. Habibur Rahman Lulu, who is a very eminent pulmonology and critical care medicine specialist from New York, USA. And I am the moderator of today's session. I'm Dr. Adnan Chaudhary. I'm the associate professor and presently working in Mugda Medical College, departmental head of respiratory medicine. And with us in the panel is Dr. Asif Mustafa Mahmood, who is the senior consultant at respiratory medicine at Asghar Ali Hospital, and who is presently serving as Secretary General Bangladesh Lung Foundation. And we have another eminent pulmonologist, Bangladesh, Dr. Zakir Hussain Sarkar, as our panelist. He is now the president of Bangladesh Interventional Pulmonology, Critical Care and Sleep Society, and is the senior consultant of respiratory medicine in Levitt Specialized Hospital. He is also serving as associate professor of respiratory medicine in National Institute of Disease of Chester Hospital. We have another panelist from Evercare Hospital, Dr. S.M. Abdullah Al Mamun. He is the presently serving as senior consultant of respiratory medicine at Evercare Hospital, Dhaka. So we are very eminent speaker and also the other expert panels. With the permission of the chair, I now request Dr. Habibur Rahman to present his topics. This is granulomatous lung disease, clinical, radiological, and histopathological approach to diagnosis. Dr. Habibur Rahman.
Adnan, if I'm allowed to say a couple of words.
Yes, of course, Appa.
Assalamu alaikum, shabaike, good morning, এবং শুভরাত্রি. Today we have a phenomenal speaker. Today we have a constellation of diseases, granulomatous lung disease, যেটা আমাদেরকে এত তাড়না করে বেড়ায় এবং we always struggle over it. How do you diagnose it? What is the clinical pathological analysis? And today we have a master speaker. I am Dr. Aisha Sigdar. I am the lead physician for Planetary Health Associates for Pulmonary Critical Care. But even more than that, a person is known by their friends. Lulu is my friend. He is my classmate. We graduated the same year from medical school. But he is somebody we all respect. Amra ashole koijon classmate ke eto respect kori. If I have a family member sick, he's the first one I call. I don't know how many times I bothered him. So we are very proud to have Dr. Lulu Habibur Rahman as a speaker. He's a well-established, he's a legend in New York in the field of pulmonology and critical care. So I'm very proud to be a part of this. আমি খুব দুঃখিত আমার চলে যেতে হচ্ছে. However, Adnan himself is a tremendous. Adnan is our dear heart. So he will be moderating the session. If I may have your leave from Adnan and the panelists and my friend Lulu, I will listen to the recorded version. I think Jakir has joined. So thank you very much. You guys are absolutely amazing. I feel so proud to be everybody's colleague or friend. Thank you, Adnan. Thank you, Lulu.
I cannot thank you enough for your extraordinarily kind words. You know, that melts my heart with the gratitude that language can, language fails to express. Thank you so much. So, bhalo theko tumi. Amra tole shuru kori naki?
Dua koro.
Acha, thank you. Okay, shabaike salam, assalamu alaikum. We're going to talk about granulomatous lung disease. As you all know, that a granuloma simply is a collection of activated macrophage and Langerhans cells and specialized trained lymphocytes trying to contain a foreign agent that could otherwise not be destroyed or digested. So that is body's mechanism to prevent the spread and contain it. So that is the main immunological purpose, physiological purpose of granuloma formations, and a wide range of conditions can present with granulomatous inflammations. And I hope to review briefly some of those conditions with you today. So it's very difficult to start a talk on any long topic without reviewing the basic anatomical structure, because understanding the histopathological findings or reading a CT scan or an X-ray properly, skillfully, requires the basic knowledge of the anatomy of the lungs. And I'm sure that this audience, especially for the lung doctor, is probably not that important because we all are trained about these things in the very first year of your training. But in case there is any non-pulmonary physicians in the group, I would like to briefly review this foundational anatomy of the lungs that is required, the knowledge of which is required to interpret the CT scans. So as you know, the lung, the trachea, the bronchi divides up to 23 times, and beyond 17 generation, the terminal bronchiole, 17 or 18 generation, the terminal bronchiole enters into a part of the lung we call secondary lobule. And the secondary lobule is very important because it is the smallest part of the lung that can be visible in a CT scan, which is clearly separated from the surrounding secondary lobules with well-formed connective tissue septa and the structure that goes with that. As you can see here, you see the connective septa, the secondary lobule, here the terminal bronchiole entering, dividing into respiratory bronchiole and then terminal respiratory bronchiole. And at the end of terminal respiratory bronchioles, you have alveolar ducts and alveoli forming the primary acini. And along the septum, the boundary of the secondary lobule, runs the lymphatics and the pulmonary venule. And so therefore, diseases that involve the veins and the lymphatic structure dominates around the periphery of the secondary lobule. And at the center of the lobule, obviously, there is another lymphatic chain, which is the minor lymphatic chain, but primarily you have the branches of the bronchial artery and the vessel that goes with that. And a centrilobular disease would generally be located around the bronchus and vessels within the secondary lobule. And the diseases like, inhalational antigen-related immunological response, such as hypersensitivity pneumonitis, and many more that we'll be talking about, will generally present in the center of the lobules. As we walk through the slides, I will try to clarify more and more with real-life CT scans so that this structure can be correlated with the actual findings in the image. So here is a little bit more real-life pictures. You can see on your right side that the second lobule is separating the lobules. Some of them are polygonal. You can see the connective septum. And here in the cartoon, you can see the secondary lobule starting with the terminal bronchiole getting in and proliferating into respiratory bronchioles. Eventually, about 3 to 20 primary acini is generally present in the secondary lobule. Their size varies in different parts of the lung. Usually it's larger in the upper part of the lung. And once again, is the boundary. Let us remind ourselves that the lymphatic system begins at the visceral pleura and travels along the secondary lobular septi and then follows the bronchovascular bundle towards the hilum and lymph node and so forth. So therefore, the lymphatic diseases such as sarcoidosis, berylliosis, or lymphangitis carcinomatosis, and so forth, we'll see that they tend to dominate in this anatomical distribution as opposed to central lobular diseases such as hypersensitivity pneumonitis and others tend to dominate with the center of the lobule. Here you see one of the most commonly used still, X-rays. Not everybody gets a CT scan initially. When you see this X-ray, you see these lines. These lines are actually prominent septal lines. These are actually secondary lobular septal lines, so-called Carley's lines. And if you use a lung sonogram, you can see the increased B lines here, dominant B lines spreading from the pleura. So that is something that, one of the earliest extra readers get familiar with. Here, a little bit more clearly, you can see in the CT scan, these are all secondary lobules. There you see the central lobular artery and accompanying bronchus with that secondary lobule. Here is another secondary lobule with the central lobular artery. If the secondary lobular boundary is prominent bilaterally and is symmetrical and is bilateral, then very likely this is venous congestion, chronic venous congestions. But if it is unilateral, then obviously it could have a bunch of other differential diagnoses, including lymphangitic carcinomatosis. So whether it's bilateral, whether it's smooth or it's nodular, that helps us distinguish one disease entities from the others. And of course, you can see a similar findings in veno-occlusive disease and very, very rarely certain diseases like pulmonary alveolar proteinosis, where you see this kind of patterns. To give you some examples of the central lobular disease, there you see that you have the bronchioles. The basic criteria that we really use to separate the central lobular disease from the axial disease or lymphatic disease or random disease, which is all over the place in the lungs, is that the central lobular disease tend to respect the fissural lines. You can see a distance from the fissure, tend not to involve the fissure, and also maintains like a highway. I call it belt parkway like highway. Around the lung, you can see a faint black line. Right before that, the bronchiovascular marking stops, and you see the changes there, opacity, branching opacity is there. So maintaining a distance from the pleura, maintaining distance from the fissural line generally indicates that the disease is central lobular in nature. And in this case, you can see that the bronchioles are dilated, they're branching, forming tree and bud. So this is obviously, histologically, this will corroborate with cellular bronchiolitis. In this case, you see the nodules, they are central lobular, faint central lobular nodules. Right down here, you see the central lobular emphysema. Barely perceptible wall, you cannot see the wall, but if you look carefully, you see a vessel at the center. You see a vessel at the center. You see a vessel at the center. When you see a vessel, means there is an accompanying bronchus also, and then there is emphysema around it with the barely perceptible walls. That is a classic of central lobular emphysema, and it is an example of central lobular disease. Here you see an ipsilateral changes, prominent thickening of the secondary lobular septi. And here also you can see the central lobular artery. So what could that be? Typically, when you see this kind of findings, ipsilateral secondary lobular septal thickening may or may not be nodular, we think about lymphangitic carcinomatosis. It will be extremely rare or relatively rare in certain lymphomas, one can present like that, or very, very rarely, atypically, organizing pneumonia can present like that. And exceptionally rarely when you have, for example, left upper pulmonary vein being narrowed, constricted after radiofrequency ablations. So now you have a particular venous distribution has a high pressure, so you have a local regional prominence of the secondary lobular septi. That is exceedingly rare, but those having that knowledge can be sometimes helpful. So let's talk about some basics about the granuloma formations. Without going through the details of the slides, let us remind ourselves, at least refresh our memory, that basically all kind of cells that normally participates in the innate and adaptive immunity, they generally contribute to the granuloma formations. So you have dendritic cells, giant cells, monocyte, mast cells, neutrophils, the regulatory T cells, Th1 and 17 helper cells, of course, the tissue histiocytes and the fibroblasts. I don't want to go through the details, but at least I would like to mention that when you have these foreign agents, foreign antigen, then the mast cells get activated, and then that stimulates the polymorphonuclear leukocytes. At the same time, the chemical product would attract the natural killer cells that releases interferon gamma, and then it's activated macrophages, and interferon gamma releases multiples of chemokine ligands that eventually also stimulates the polymorphonuclear leukocytes. And through a separate pathway, now the lymphocytes are activated, and then at the same time, the tissue antigen presenting cells would also get the information through interferon gamma, and then they travel to the lymph nodes and they train the lymphocytes in the TH direction, and after training, the releases a series of chemicals, and then eventually the combinations of the lymphocytes and the fibroblast and the activated macrophage, when in the tissue we call it histocytes, and they change to epithelial cells and form the granuloma. So if you look at the granuloma, what you see in the periphery is a fibrous ring. This is a mature granuloma. Classic example would be sarcoid granuloma. And then we have a group of lymphocytes surrounding that, immediately next to that. And then, of course, you can have at the center giant cells. And along with that, sometimes we see some product of the granulomatous inflammatory cells like Schumann bodies and, starry appearance particles. So basically, the giant cells surrounded by lymphocytes, surrounded by fibroblasts, that gives the nature and appearance of the mature granuloma. Now, when the macrophage is exposed to a foreign antigen and it's trying to deal with the foreign antigen, initially releases interferon gamma and endotoxins and other chemical substances, and through IL-1, 12, and 23, reactive oxygen species, and nitric oxide synthetase, lysosomal enzymes within the macrophages, and tends to cause damage or destruction of the organism. And at the same time, of course, there is inflammation. So inflammation and destruction. On the other hand, when that becomes very difficult, or it's not easy, or the antigenic stimulation continues for a long time, then of course the second pathway, we call it M2 pathway. Okay, simply put, M1 pathway is microbicidals, and M2 pathway is the pathway that leads to granuloma formations, where you have tissue repair and fibrosis, and at some point, anti-inflammatory balancing of the mechanism so that the body's physiology come to a relative homeostasis and rest. So I'm going to present you a case quickly. And this is a 50-year-old Caucasian woman, and she was in an usual state of health, and then she developed mild upper respiratory tract infection, what is considered to be mild upper respiratory tract infections. And that during the recovery phase of that illness, she was bothered by the persistent bronchitis and a mildly productive cough. And on advice from her physician husband, she started some self-management, and she was told to use hot moisturized air and in an indoor hot water soaking tub, where she would use a towel, soak towel, and it's like a sauna-like temperature. It's a lot of humidifications, and then breathe through the towel to feel better. And she did that daily. However, over the next few weeks, her cough persisted and was progressively accompanied by shortness of breath. And then the CT scan of the chest was ordered by physicians. And here you see these findings. What we are seeing here is opacifications, faint opacification, ground glass opacifications, mainly involved in the secondary lobule. You can see the secondary lobule, secondary lobule, secondary lobule. So predominantly in the secondary lobular distributions, there is this opacities, and in between there appears to be a faint mosaic patterns. So when you see that, and it's not extending up to the pleura, relatively free, stopping right here. So obviously this is a bronchocentric disease, and the faint opacity in ground glass would suggest that there is very likely inflammation there, which is mostly in the secondary lobule. So it's very suggestive that a particular antigen, probably inhaled antigen, a foreign body, is traveling through the airway and reaching the distal part of the airway, stimulating the local inflammatory cells, the macrophage and tissue histiocytes, and then bringing about inflammatory changes, exudations of fluid, etc., giving that ground glass appearance limited to the secondary lobule. So that's very, very classic of hypersensitive pneumonitis. In case you have a biopsy, sometimes it's not easy, but having a very good history and that characteristic findings would strongly suggest the possibility of hypersensitive pneumonitis. As you know, it can be acute, subacute, or chronic, and in between as well. And depending on duration of the antigen exposure, whether or not body is having an acute dramatic reactions or a slow chronic reactions, the appearance in the CT scan as well as in the histopathology can change. So if you look at these slides, what we see some airway, you see the bronchi here, and you see the most of the activities are going on around the airways. Most of the activities are going on around the airways. So when you see that in a low power slide, that is suggestive of bronchocentric disease. Here we see the lymphatics, we don't see a lot of abnormalities in the lymphatics. So again, in the low power view, when you see that, it's very, very suggestive of a bronchocentric disease. And then if you expand it further, then you see these focal aggregates of many, many nucleated cells in different parts of the lung, not homogeneous. This would be a little bit atypical, but closest differential would be non-specific interstitial pneumonia. But if you look carefully and zoom it out, and then you see the disease is predominantly around the bronchus. You have lots of lymphocytes. Most typically, the hypersensitive pneumonitis would show loosely from granuloma. It's not very mature granuloma like sarcoidosis. Matured coalescent granuloma, as you'll be seeing in sarcoid, that's not what we see in hypersensitive pneumonitis. Here you have a loosely formed granuloma, epithelial cells attempting to form granuloma formations, and you see peribronchial infiltration of cells, particularly lymphocytes, a little bit spill over into the interstitium. So peribronchial domination, lymphocytic infiltrate, minimal cellular infiltration within the parenchyma, and loosely formed granuloma. That is very, very characteristic of hypersensitive pneumonitis. And the closest differential probably would be lymphocytic interstitial pneumonia that can occasionally look very, very similar, and sometimes it is difficult to distinguish one from the other. A very good lung pathologist and the detailed history exam properly and contextually putting things together can distinguish one from the other. And not always done, because when you see granuloma, rarely you will see, I don't know what is your experience back in Bangladesh, but auramine, rhodamine staining is not very common. Usually they can do a gel-needle stain, but because it's very, very cumbersome for the pathologist. But in this particular case, an AR stain was done, and you can see an acid-fast bacilli. So the question is, what is the diagnosis?
Atypical mycobacteria. Atypical
Correct.
mycobacteria, maybe Mycobacterium avium intercellular.
Wonderful. So let's go over now, let's analyze the case. So let's mention 4 domains. One is the clinical and laboratory presentation. The patient had a slowly progressive dyspnea cough, and we came to know the patient was using hot tub, sauna, high humidity. And radiologically, there was bilateral ill-defined central lobular nodules, mostly in the upper lung zones. And then pathologically, we noticed interstitial chronic inflammation and non-necrotizing granulomas. And of course, we found the acid-fast organism. So this is the classic of what is we call sauna lung or hot tub lung. This particular patient was treated with low-dose corticosteroid and improved. And sometimes you may need the antimicrobial agents along with corticosteroid, and certainly environmental management is the most important key, because if the patient keeps on being exposed to the same environment, then it's going to be next to impossible to eradicate the process. Now, MSc, our goal is not to go into the details of Mycobacterium avium intracellularly today because it by itself is a huge, huge topic. But just to mention that MSc in relatively immunocompetent patients can give a classic fibrocaseous disease, fibrocapillary disease in the upper lung zones, very similar to Mycobacterium tuberculosis complex. In severely immunocompromised patient, the disease can disseminate and involve the various organs. And it can also present with lobar consolidation with or without necrosis, nodular changes, endobronchial fleshy lesions is not so uncommon. It's not often thought of, but endobronchial non-tuberculous mycobacteria is within the spectrum. There's 7 or 8 different types of presentations. And of course, the diffuse interstitial and nodular disease that we can see, as for example, in this particular case, there's a hypersensitivity reaction involved in this process, the so-called hot tub lung. So you have organism, direct effect organism, but predominant pathophysiology is a hypersensitivity type of reactions to the organism, creating that pneumonitis. Very, very rarely, eosinophilic pneumonia we can see in MSc. Now, to going over some of the other radiological patterns, mentioning within the spectrum some of the different kind of presentations of the HP. As you can see here, it's relatively acute or subacute. Here you see a ground glass patterns, a mosaic attenuations. And if you look at the mosaic attenuation, they have a lobular type of mosaic attenuations. This is very, very important to notice. If you see a lobular type of mosaic attenuation, that is very, very suggestive of hypersensitivity pneumonitis. You can see that here. Even when there is a relative chronicity, in this case, you can see some traction changes. You can see some degree of remodeling and organization going on over time. It still could be subacute or being chronic over time. But almost always, except in highly advanced cases, we can see the preservation of the mosaic patterns. So when you see this disease, inflammatory changes, architectural distortion, but the mosaic pattern is somehow preserved, hypersensitivity pneumonitis should always be taken into consideration. Even though advanced burned out hypersensitivity pneumonitis sometimes looks very similar to an UIP-like patterns, but still even in those cases, many of them will show this kind of mosaic patterns. And that should remind the clinicians the possibility of fibrotic chronic HP. Again, a few more examples, depending on the chronicities. You can see very acute cases. In this case, also, you see the mosaic patterns. You can see the central lobular distribution because it's not touching the visceral pleura. Here you see the lobular opacities. As it gets more and more chronic, you see reticular changes and traction changes. But even in those cases, as I mentioned earlier, you continue to see a mosaic attenuation in the lobular distribution. This is very different from the mosaic attenuation that you may see in the lobar distribution, where you can have a vascular obstruction or vascular agenesis or something going on, or vasculitis, for example, large vessel vasculitis. But this lobular type of mosaic pattern is very suggestive of hypersensitivity pneumonitis. Now, it's a boring slide, but let us, please bear with me. Let's walk through these slides because it's very, very important to go over some of the common differential diagnosis of granulomatous lung disease. So under the major category, you have infectious disease and non-infectious inflammatory diseases. And among the non-infectious, there are multiple headings, including exposure and vasculitis and autoimmune diseases. So to briefly mention, among the infectious category that leads to granulomatous inflammation in the lungs, you have mycobacterial disease and various kind of fungal disease, particularly endemic fungi, histoplasma, coccidio, and blasto and paracoccidiomycosis. Here in America, we get blasto and coccidio, paracoccidio, mostly in Nevada, Arizona, and of course, the people coming from the South America. I think I read a paper that in Bangladesh, one of those papers, I saw like 16 cases of histoplasmosis, but you probably don't have as much blasto or coccidio mycosis in Bangladesh, to my knowledge. I know that there is aspergillus, obviously, especially in asthmatics with bronchiectasis and ABPA that can present with bronchocentric granulomatosis. But I would think that you don't have many of these endemic fungi except maybe histo. Cryptococcus is, of course, is ubiquitous, so it's all over the world. So that is the infectious category, and very, very rarely tularemia and cat's craze and Whipple's disease. That's not very common, as you all know. Under the inflammatory headings, you have sarcoidosis, necrotizing sarcoid granulomatosis. I will explain that a little bit more, the distinction between the two. Bronchocentric granulomatosis, inflammatory bowel disease, and all the exposure-related issues, low molecular weight proteins that leads to episode of pneumonitis. Let us not forget some of the drugs that can present with granulomatous pneumonitis, methotrexate being one of the most prominent one. But BCG is not used routinely for vaccination now in most of the world, but is also used, as you know, in bladder cancer. So that can lead to dissemination of the BCG, causing BCGiosis and diffuse granuloma formations. We had a case many, many years ago. And immunomodulated medication like infliximab and etanercept and leflunomide, even mesalamines and sirolimus, they can present with granulomatous lung disease. Hot tub lung, of course, we presented the case to you. Berylliosis, getting a very good history of exposure. Without the exposure history, beryllium and sarcoid looks very, very similar, as you know. And unless the suspicion is there, we're not going to ask for, beryllium-associated lymphocytic transformation test, so the diagnosis can be missed. Talc is not very uncommon, as you know. Many medications have magnesium silicate as part of the preparations, and people can crush that and then mix with water and inject in their system, giving foreign body granulomatosis in the lungs, and certainly inhaled metals like aluminum and zirconium. Foreign body granuloma is extremely common, particularly aspiration pneumonia. And then the vasculitis category, particularly this medium and small vessel vasculitis, where you have a GPA, granulomatous polyangiitis, and EGPA, eosinophilic granulomatous. That is a particular category. If you have a very large vessel vasculitis, tend not to involve the lung as much, extremely rarely, like giant cell arteritis, etc. And of course, a very, very small at the venular level, such as in hypocomplementemic vasculitis or cryoglomerular vasculitis, they tend not to form much granuloma there. But it's mainly the ANCA-associated vasculitis that we have to keep in mind. And then among the autoimmune diseases, the rheumatoid nodules can give a granulomatous inflammations. The specific characteristic that distinguishes rheumatic nodule or another process that looks very similar, like inflammatory bowel disease, where you have aseptic sterile necrosis in the center of the nodules. We'll talk about that a little bit more later. And then last but not least, you have lymphomatoid granulomatosis, Langerhans cell histiocytosis, and so-called GILD, the granulomatous lymphocytic interstitial lung disease that typically is associated with common variable immunodeficiency syndromes. So I understand that it's quite boring, but I think that whatever we can keep from here as a lung doctor, and certainly for the internist as well, whenever the pathologist report a granulomatous inflammation, we really have to look at the whole horizon of possibilities and then see what clinically makes sense best. So now in this particular patients, and of course in other patients as well, whenever we are reported by the pathologist that a certain sample shows granulomatous inflammatory reactions, there are some of the things as clinicians we have to take into considerations. For example, are the granulomas scattered or single? In that case, think about infection, aspiration, pneumonia. They're very mature coalescent granuloma. Lots of granulomas, they're matured and monotonous, very similar looking. Think about sarcoidosis. Sometimes asteroid bodies and Schumann bodies, they're birefringent material that can be seen in a well-formed granuloma chronically. They're usually non-specific because any granuloma that is old and matured, those observations can be made. If there is extensive fibrosis around the granuloma, and of course the matured granuloma, then sarcoidosis and chronic aspiration, recurrent aspiration should be taken into consideration. Of course, the aspiration-related granuloma will have other additional characteristics, such as a foreign body type of granulomas. There can be, fats within the macrophages, foamy macrophages. Um, Even vegetable cells can be seen there. So combination of those things and a good history can separate, because that is a very, very common condition. There was a paper published many years ago where they looked at the etiology of granulomatous lung disease. A high percentage of those patients had chronic recurrent aspiration. So it can easily can be missed unless you get a good history and then get the details of the granulomas as reported by the pathologist. If there's a lot of mononuclear cells around the granulomas, possibility of infection, hyperpneumonitis, and if there's a lot of lymphocytes, then we should ask the pathologist to do some flow cytometry and send them to the immunohistochemistry and find out whether or not there is a clonality, whether or not this is a lymphoproliferative disorder. Now, going further into the natures and characteristics of granulomas, if the granulomas are very well formed, as I mentioned earlier, sarcoidosis and aspiration infection, loosely formed granulomas, where you have these, histocytes turning into epithelioid cells and trying to organize. So you have the monocyte, macrophage, histocyte, activated histocyte, turning into epithelioid cells, attempting to form a granuloma surrounding. That is a loosely formed granuloma by definition. That would be in hyperpneumonitis, maybe in LIP, among the lymphoproliferative disorders, and drug-induced lung disease like methotrexate and others, which I mentioned to you. If the granulomas are only seen as an isolated giant cells, just sporadic here and there, hard metal disease is possible, zirconium being one of them. Cobalt pneumonia is separate because it is a separate entity now. Hyperpneumonitis can, because the pathologist, the lung pathologist with a lot of expertise, they may report they see fibrosis, non-specific fibrosis, but there is a little bit of inflammation, but mostly they're centered around the bronchioles, and there is, an isolated giant cells. This may be suggestive of chronic hyperpneumonitis, clinical correlation recommended. That is how they will put the report, and it is on our shoulder as clinician to put everything together and to make a meaningful conclusion and diagnosis. And if the granulomas are necrotizing, and what is the nature of necrosis? I'll talk a little bit more about the nature of the necrosis and distinguishing one from the other. And then again, you can see the necrosis in vasculitis, like GPA, or infectious conditions. Let us remind ourselves once again to refresh our memory. Airway center granulomas are generally inhalational in nature, such as aspirations. The granulomas along the lymphatic channels, the classic of sarcoidosis and berylliosis, and less commonly, we don't see much silicosis. Angiocentric granulomas can be seen in sarcoidosis. This is not the classic necrotizing sarcoid vasculitis, so obviously that is a different entity. But more than 50% of the time, the pathologist will tell you that there is granuloma all around the vessels, but it rarely invades the vessels. So because it does not invade the vessels, you cannot call it vasculitis. But angiocentric granuloma is quite common in sarcoidosis. And of course, intravenous drug users, where the drug through the pulmonary vein, it settles in the bronchovascular bundle area, small distally, and around that area stimulates the immune cells to produce granulomas. Talcosis being the classic examples. But random granuloma all over the place does not follow a lymphatic distributions or centrilobular patterns. That's very typical of miliary infection, could be miliary TB or miliary histoplasmosis or any other endemic fungi. I would think that you rarely are confronted with this challenge, but if and when you have a good history and a pathologist is saying it is looks like matured coalescent granuloma like sarcoidosis, but looks a little bit more blue, somewhere between hyperpneumonitis and sarcoid. So think about other possibilities. But most of the time they look very, very similar. Their distribution anatomically is very similar. But if there's a little bit more bluish characteristic looking more like an HP sarcoid combination, we should definitely ask for beryllium-associated lymphocytic transformation test when it is clinically relevant. Now, between Sjogren's syndrome and the immunodeficiency syndrome, particularly GILD, associated with common variable immunodeficiencies, both these conditions have a lot of lymphocytes centered around the airways and secondary and the follicles in the bulk distribution of the anatomy. But one difference between Sjogren and the immunodeficiency syndrome is in Sjogren, you can see a follicular expansion, a secondary follicle. But in immunodeficiency syndrome, they tend not to have much secondary follicle. And of course, if you look at the immunohistochemistry, there will be a lot of lymphocytes. And if those lymphocytes are mostly at the center of the follicle, then that is generally benign. But if they're all over the place, then we as clinicians, we have to request the pathologist to stain it, do the flow cytometry, because there could be clonalities. And they would generally stain for CD20. And if the CD20 is widely positive beyond the follicular distributions, then one has to consider the possibility of a lymphoma. This rarely I would think that you would encounter this situation, but because ultimately the diagnosis is on the shoulder of the clinicians, and you don't have lung pathologists in most part of the world, so try to get as much as you can from the pathologist. Please describe to me what you're seeing. What is the distribution? What are the changes? What is the background? And then we as clinicians, we have to have a sound knowledge of pathology and then be able to put together the history, the radiological findings, and the findings reported by the pathologist to come up with the clinical diagnosis. So now switching gear, here we see a patient, very likely the patient could have some sinus disease, nasal disease, or airway related symptoms, cough, or difficulty breathing, stridor, could have hematuria, constitutional symptoms. And then we see multiple nodules within the lungs, obviously vasculitis, particularly granulomatous polyangiitis, and similar vasculitis should be considered in the differential diagnosis. Here is an example of what you would call a random distribution of small nodules, 1 to 3 millimeter in size. Random means hematogenous, hemolymphogenous, but it could be purely hematogenous. When the distribution is purely hematogenous, the nodules falls all over the place. They can fall a little bit on the fissure line where you have the lymphatics. They can fall on the pleura, and they're not in a particular part of the secondary lobules. They're all over the place. This random distribution is very, very suggestive of a hematogenous spread of a condition. Could be malignancy, could be infections such as TB, histo, and others. So whenever we see this random distribution in the proper clinical context, we have to consider possibility of miliary infection or miliary spread of tumors. If you look at the histopathology here, you see a vessel, and around the vessels you have lots of granulomatous inflammation here and some necrosis here. So this is necrosis, granulomatous inflammation centered around the vessels. So this is a miliary tuberculosis that is not necessarily invading the vessel, even though sometimes you can see secondary vasculitis because it's invading. But in this case, you don't see a lot of invasion, but it's the perivascular distribution. Because this is hematogenous, it's miliary, that's why we are seeing all this inflammation around the vasculature. This is a case of acute case of coccidiomycosis. I don't know if any of you have seen coccidio in Bangladesh. Please share at the end. We rarely see that in New York, but it's much more common in Arizona and Nevada and California and those places, and people migrating from South America. There is pretty high incidence. So if they see an X-ray like this, pretty top in the differential diagnosis, they would consider coccidiomycosis in the differential diagnosis. If it is Ohio, Mississippi River Valley, they would consider possibly histoplasmosis as well in their differential diagnosis. And there you see this bilateral round opacities, vaguely defined. And then you look at the mediastinal window, you see a lymph node. So you have lung opacities with the lymph nodes, the possibility of a fungal infection is highly likely. Vasculitis will rarely give you a lymph node except EGPA, eosinophilic granulomatous polyangiitis. that is also relatively rare. And even necrotizing sarcoid vasculitis will also generally not associated with a lot of lymphadenopathy. So when there is this masses like this, maybe patient may have cough, constitutional symptoms, and there's lymphadenopathy. With the right clinical context, one has to think about the possibility of endemic fungal infection. So history and exposure, that is why particularly in lung disease, environmental history, occupational history, drug history are extremely, extremely important, not to mention the family history as well. A patient with rheumatoid arthritis typically could be male, more than female, smoker, usually have a high rheumatoid factor levels, and usually has a rheumatoid arthritis for a long, long time. So long time, possibly smoker, male more than female, high rheumatoid factor level, and then you see this peripheral necrotic rounded lesions. So one has to think pretty strongly about the possibility of necrobiotic nodules. Rarely though, but it is also, it can be seen in Crohn's disease and much less likely ulcerative colitis. And when you look at the necrobiotic nodules under microscope, what we see is the central necrosis. A PCR is negative, it is sterile. And then surrounding that, we see palisading histiocytes. And then, of course, fibrosis and giant cell occasionally. So when there's a necrosis, sterile necrosis, and palisading histiocytes, the differential diagnosis become relatively narrow. And certainly necrobiotic nodules would be, in the right context, would be pretty high in your differential diagnosis. In this case, you can see the necrobiotic nodules has ruptured into the pleural space, giving loculated pneumothorax. You can see that here as well. Now, if you look at this image, what do we see? We see lots of nodules. They seem to be randomly distributed. We see a series of lymph nodes here, and the lymph node has a much more lucent center and the surrounding prominence, enhancement. You can see enhancement, enhancement. So when you see that, that's very strongly suggestive of necrosis. And so you have a necrosis with enhancement. That is very characteristic of either tuberculosis or histoplasmosis, rarely other endemic fungi. And then, of course, there is parenchymal lung disease. And if you look at it, the lymph node in the mediastinum has necrosed and burst into the esophagus, and then that is causing damage. And there you see spillover into the pleural space, giving pneumothorax. So this would probably be more likely between histo and tuberculosis. I would say probably histoplasmosis more likely because of medicinal involvement and necrosis and damage, which is rarely seen in tuberculosis. And both can have a necrotic lymph node with peripheral ring enhancement. I guess context would be very, very helpful. If it is in a place where histoplasma is exceedingly rare, one would think about tuberculosis as a top differential diagnosis. This is another example of histoplasmosis. There you see some lymph node causing compression of the airway. But without going through the details, you know the histo can present in various ways, including nodules, histoplasmoma, mediastinal fibrosis, retroperitoneal fibrosis, compression of the airways and vasculatures, and so forth. Of course, necrotizing capillary disease, very similar to tuberculosis, involving the upper lung, can also be seen in histoplasmosis. Here is a case of coccidio. You see the lung opacities, nodules, and then of course the lymph node, subcarinal lymph node, and the hilar lymph node expansions. You can see that here, subcarinal and hilar. And then look at the histopathology, you see lots of giant cells. It's the granulomatous inflammatory reactions. This may be a cholesterol cleft within this, and sometimes within the giant cells, one can see an yeast form of the fungus that would be extremely diagnostic. But in this case, the pathologist might report there is granulomatous inflammations and giant cell formations, and the differential diagnosis includes 1, 2, 3, 4, 5. So in this case, clinician possibly will ask for fungal stain, maybe PCR when it is available to see whether or not it's tuberculosis, or something else before we can make a decision about the management. You can see a manifestation, EGPA, eosinophilic granulomatous polyangiitis, also involves the lung in many different ways. I will show you some of the slides where you see you can have nodules about 70% of the time maybe in the bronchovascular distribution. It can be patchy opacities, very faint ground glass, depending on which part of the lung it is involved in. If it is eosinophilic infiltration around the airways, you can see some centrilobular features. It can extend to the interstitium parenchyma. You can see ground glass opacities. It can appear as a mass with rarely necrosis. Necrosis is very, very uncommon. Medicinal adipathy can rarely be seen. Proliferation can be seen. Also, proliferation can be due to myocardial involvement, because myocardial involvement with myocarditis, myocardial edema, and drop in systolic function can potentially contribute to proliferation as well. So there's a wide variety of manifestations, but a patient usually with a long history of rhinosinus disease, atopy, congestion, peripheral eosinophilia, maybe with some mononeuritis, some peripheral neuropathy, cardiac manifestations, with or without renal manifestation. When you see the systemic involvement in such a patient, must always take into consideration the possibility of ANCA-associated vasculitis, particularly EGPA. Here is a few more examples of the spectrum of the radiological manifestation in the chest. There you see this central airway, and around which, in this case, the lobular presentations. And histopathological, this would look like a lot of eosinophils accumulating here, causing inflammation. And there can be, obviously, vasculitis is the most important finding that we're looking for. And eosinophilic infiltration of the vessel, that will be eosinophilic vasculitis. And that is highly, highly suggestive of EGPA. Here you see it's kind of lobular presentation, ground glass, suggesting eosinophilic infiltrations. And it's almost like, unless the vasculitis part is critically looked into or critically taken into considerations, one may simply cause it a very atypical presentation of chronic eosinophilic pneumonia. But it's the vasculitis that would distinguish it. And certainly the systemic manifestation as part of the criteria should be taken into consideration. Here is another where you see like segmental distributions and ground glass, where you can see the vessel and bronchus through the veil, all because of infiltrations of eosinophils and small vessel vasculitis. Again, shifting back and forth, this is GPA, granulomatous polyangiitis, otherwise called Wegener's disease. When you see these cavitations and nodules, that is far less common in EGPA. So certainly Wegener would come into consideration. ANCA is very, very helpful, C-ANCA in particular. And then you have the sinus thickening, and of course the lung nodules with cavity formations. So that's very, very classic presentations of GPA. In this particular slide, we see the vessels, and the vessel is invaded by cells, distorted and damaged. The wall of the vessel is damaged, and then those cells have eosinophilic nucleus. So these are all eosinophil invading and destroying the vessels. This is an eosinophilic vasculitis, and I'm sorry, this is actually lymphocytes, and it's a lymphocyte going all around the vasculatures. I forgot to notice the blue cells there. And when you see that vascular invasions of a lot of lymphocytes, not polys, the polymorph nuclear leukocytes is very classic of GPA. But when you see lymphocytic infiltration, not eosinophilic, think about lymphomatoid granulomatosis. However rare it is, lymphomatoid granulomatosis is a lymphoma. It's basically extranodal lymphoma connected to Epstein-Barr virus, as you know. Looks very similar to GPA. So in the right clinical context, we have to take that into consideration. Is it lymphomatoid granulomatosis? The main histological distinction would be lymphocytes rather than polymorph nuclear leukocyte invading the vessel wall. Now, clarifying a little bit about different type of necrosis, and does it give us some clue as to what is the nature, what is the etiology of necrosis? In infection-related necrosis, typically it is a round necrosis and it's eosinophilic necrosis. It is round and eosinophilic. On the other hand, in GPA, you see a basophilic necrosis and it's very, very geographical. It's very, very serpentinous. When you have serpentinous type of necrosis and it's mostly basophilic, that is very, very suggestive of vasculitis, as opposed to infection, which is round and eosinophilic. So this is an interesting slide where you see a structure around, looks like a lumen, and that lumen is captured by these images, these findings, at the center of which you have a lot of calcium-rich bodies, which is Schumann bodies. And then you have these large cells with a pale cytoplasm. So this is an interesting situation where you have vegetable cells and you have lipid-laden macrophages, very, very large, and giant cells. This is chronic aspiration. As a result of chronic aspiration, this foreign body granuloma has formed. The combination of the granuloma, the giant cells and vegetable cells and the foamy macrophages generally gives the clue. Even though foamy macrophages can be seen in many other conditions, especially in granulomatous disease, certain drug reaction like amiodarons, lipid storage disease like Niemann-Pick's disease, but Niemann-Pick does not have any granuloma formations. Combination of all those things within the bronchus certainly will point towards the possibility of, strong possibility of chronic aspiration pneumonia. Now, switching gears to another disease entities. Of course, clinically, when you see this in a patient who has bilateral hilar adenopathy, you're thinking about sarcoidosis. This is lupus sparnium. Do a very good eye examination. You can see lacrimal gland enlargement. That's the typical CT scan for sarcoidosis. Sarcoid is a great masquerader. There's a varying degree of presentation of range of presentation of sarcoidosis, starting from lobar consolidation to nodules, very rarely not even lymph node involvement, depending on the stage of sarcoidosis. And phenotypically, there are very different types of sarcoidosis. They're not all the same. But more than 80% of the time, this is the classical radiologic appearance of sarcoidosis. What we see here is a what we call axial distribution of abnormalities within the bronchovascular bundle. So you can see the thickening on the fissure, which is the lymphatic channels, in the bronchovascular bundle, which is the lymphatic channels, bronchovascular bundle, which is the lymphatic channels. So disease is traveling along the lymphatics, and it is bilateral. And often you will be accompanied by bilateral hilar adenopathy and subchoroidal adenopathy. When you see this combination, they may have some constitutional symptoms, some chest pain or cough. Rarely you can see this erythema nodosum formations. Rare variety like Lufkin syndrome has some special presentation. But apart from that, when you see this kind of radiological findings, this is highly, highly suggestive of sarcoidosis. Berylliosis, of course, will look very similar, but beryllium-related lung disease is relatively rare. We should get the appropriate exposure and occupational history. This is the example of a burnt-out sarcoidosis. You would call it stage 4 sarcoidosis, typically in the mid and upper lung zones. You see the cystic changes, bronchiectasis, dominantly in the mid and upper lung zones. That is highly, highly suggestive of sarcoidosis. Far less commonly, this could be advanced or chronic hypersemic pneumonitis. But in this kind of thick wall cyst in hypersemic pneumonitis is relatively rare. So if I see this and I'm given just to make only one diagnosis, I'm going to call it chronic sarcoidosis. And we generally, when we make a sarcoid diagnosis, we send them to ophthalmologists for examinations to look for evidence of uveitis. Of course, asking them good questions about the color visions and eye symptoms. They can give some history that can point to the diagnosis. And sometimes we get referral from the ophthalmologist because they find uveitis in their examination, and then they refer to us, to the lung clinic or TB clinic. When you do a bronchoscopy, this is what you typically see, the cobblestone appearance, right? That's very classic of endobronchial sarcoidosis. The other differential diagnosis that one may consider, which you will not see so much vascularity there, would be maybe endobronchial, amyloidosis. Uh, Tracheal papillomatosis usually do not look like that. So it's highly suggestive of endobronchial sarcoidosis. I had a patient several years ago who not only had this, but also had a very flashy, beefy, red, fleshy lesions, occluding the bronchi, and they were very vascular and was bleeding. The patient was intubated in intensive care, and we had the biopsy, and we got the result, and we started high-dose corticosteroid, and to our pleasant surprise, over the next week or two, everything resolved very quickly, and the patient eventually was extubated. There you see the different phenotypes of sarcoid presentations, including a Sosa's finger. You see lupus parnium. And when you do an MRI, the sarcoid tends to be distributed in the area of the septum, in that distributions. And you can occasionally see even pituitary involvement and punched out lesion in the bones. These are all various presentation within the sarcoid spectrum. Muscle involvement, myositis. Clinically, they do not present. Rarely you see rise of CKs, but if the biopsy is done, more than 30% of the patients will have evidence of granuloma in the muscles. Now, this is a special variety. You may or may not be familiar with the so-called your tattoo sarcoidosis. In the area of tattoo injections, the sarcoid granuloma forms, and quite interestingly, even though they tend to be localized in the skin, but they can spread. It looks like sensitizing the immune system. And I have found a couple of cases. One of them had uveitis, and another one of them had hilar adenopathy. So even though it originally is a tattoo sarcoidosis, but then it can give systemic manifestations of sarcoidosis. And this is the most typical histopathology. There you see a lymphatic channel, and it's a matured coalescing granuloma. All of them look very, very alike. The very, very matured granuloma. They have the complete structure of the granuloma. Central giant cells and lymphocytes and fibrous ring around. Monotonous matured granulomas is highly suggestive of sarcoidosis. And when they're around the lymphatics, of course, then the diagnosis is beyond question. Again, another examples of very mature granuloma sarcoidosis. I don't want to go through this in too much in details, except to mention that 95% of the time sarcoid involves the lungs, and about 15 to 20% skin, and lymph node in this case saying 15%. I think that probably that is a little bit stretch of imagination. Probably much more higher than that, there will be lymphadenopathy. But peripheral lymphadenopathy is relatively rare, but certainly mediastinal lymphadenopathy would be much more common. And then followed by that, you have eye and other organs involvement. So this is an example of a CT image of a lymphomatoid granulomatosis. What we're seeing is the multiple masses, small and big. In this case, they're both peripheral, mostly peripheral, but some of them are relatively central. So it's very, very difficult to distinguish from other conditions, particularly GPA, granulomatous polyangiitis. But as I showed you the histopathology, when you look at the histopathology, you see lymphocytic vasculitis. And then, of course, you do flow cytometry and immunohistochemistry, we find out clonality. And this is a, Epstein-Barr virus-induced extranodal lymphoma within the spectrum of pulmonary lymphoma. Now, asthma is very common all over the world, and many asthmatics, they're not necessarily followed routinely or regularly with the doctors, not to talk about lung doctors, and they end up having bronchiectasis and then eventually get colonized with aspergillus. And with aspergillus colonizations, a local hypersensitivity type of reactions can be elicited, and then there's lots of mucus formations, and the hypersensitivity reactions can lead to destruction of the wall of the bronchus, causing necrosis. So it's a necrotizing bronchial invasion. And so, and radiologically, that can look like a peripheral mass. Sometimes you would see a finger and globe-like appearance where you had mucus, bronchiectasis, and then eventually bronchocentric granulomatosis as a result of persistent chronic inflammations. What is the characteristic histological findings? Here there will be necrosis, but the necrosis will invade the bronchial wall. It will be bronchocentric. And so usually that is 50% of the time associated with the asthma and associated ABPA, rarely can be associated with the vasculitis as well, and other bronchiectasis that get colonized by the fungus. So not so uncommon these days, intravenous drugs, even though it is a little bit, perhaps the trend is a little bit less than before, but intravenous drug is still very, very common, and people knows all different ways to crush drugs, mix with fluid, mix with saline, and then inject into their veins. And typically going through the veins, they produce centrilobular nodules. And there you see this random nodule all over the place. They're small nodules, and this is actually not centrilobular, this is a random nodule. Sorry about that. And distributed through the vessels. And then as a result of vascular obstruction over time, you can see evidence of pulmonary hypertension. So you see some pruning of the peripheral vasculature, a prominent pulmonary artery, and this random distribution of nodules. So this is a talc granulomatosis. Even though it's relatively rare, pulmonary hyalinizing granuloma, when you have very, very high calcium and you see nodules within the lungs, the differential is very limited. It is either pulmonary hyalinizing granuloma or you have amyloids, and less commonly maybe hematoma that gets calcified. Those are some of the differentials, especially when there's too much calcium into the system. And histopathologically, you would see layers of the lamellae, layers after layers like an onion. And why that happens is very unclear, but it's an atypical immunological response, possibly to infection. Maybe it's a burnt out myofibroblastic tumor, or some other kind of immune reaction against infection, very similar to fibrosing metastenitis or retroperitoneal fibrosis, as we see in histoplasmosis and other conditions. So this is within that spectrum of body's immune reactions, one can form pulmonary hyalinizing granuloma. Now, I think it is important that we mention a little bit about inflammatory bowel disease associated lung disease. IBD is common worldwide, both Crohn's and ulcerative colitis, and that these IBDs are basically systemic diseases. Even though we call it IBD, it can involve the lungs, spines, other connective tissues, eyes. So we have to have a decent workable knowledge when the patient has this IBD and have lung findings, which can be widely variable. You can see a tracheal narrowing, tracheitis, tracheal stenosis. You can have eosinophilic pneumonia, especially the patients who are in sulfasalazine. Bronchiolitis and bronchiectasis is very, very common. One can have granulomatous bronchiolitis in the histopathology. But if you look at an image, you see a bronchocentric disease, evidence of bronchiolitis. There you see a secondary lobular involvement and mosaic pattern suggesting bronchiolitis. But as I said, a wide spectrum of manifestations, very rarely pleural effusions and lymphadenopathy, but mostly it is bronchocentric and parenchymal disease. And there is involvement here. In this case, you're seeing narrowing of the trachea. That will be typical of Crohn's disease rather than ulcerative colitis. Again, a few more examples where you can see organizing pneumonia-like patterns, which is also quite common in both Crohn's and ulcerative. Ulcerative is much more common than Crohn's, OP, and the lower concentration with architectural destruction can be seen as well. And in chronic cases, it can be very, very reticular with traction changes. Now, Other bronchocentric disease with granuloma formations, particularly stellate granuloma, the classic example being PLCH, the so-called eosinophilic granuloma. There, the granuloma, we see early phase, you see nodules, mostly in the upper lung, usually young or middle-aged smokers. And you see nodules in the mid to upper lung zones, tend to be centrilobular because they're around the airway. And then over time, it forms cysts because you have inflammation around the small bronchiole, and then the inflammatory cells, the macrophage and histiocytes, joined by the lymphocytes, they lay down, stimulate fibrosis, and then as a result of traction, opens up the airway, forming cyst. So there is ragged, irregular, scarred cyst formations, predominantly in the upper lung zones, mid to upper lung zones, sparing the costophrenic angle, smoker, is highly suggestive of PLCH. And it is actually, at least 50% of the time, you can see a BRAF mutation here. It is now increasingly appearing to be some kind of myeloproliferative disorder. And the treatment is obviously smoking cessation, as you know. I do not think that you're going to encounter these things except in pulmonary board, and that is why we discuss this, because in the board question, they like to throw one or two of this. This is a case of granulomatous lung disease, Ardheim-Chester's disease in this particular case. The typical finding here is secondary lobular septal thickening. And when you do a histopathology of that, and certainly there could be bone involvement, and the bone pain is very common. And histopathology shows a lot of histiocytes, but they are not non-Langerhans cell histiocytes. They are not classical Langerhans cells. And what is the difference? The Langerhans cells, such as in PLCH, will have a CD1A positive, S100 protein positive, but these cells are CD1A and S100 protein negative, and they're positive for CD68. So when you see that, and most of them will have systemic manifestations, roughly around 30% will have lung involvement. That is very classic of Ardheim-Chester's disease. And again, I think it's extremely rare. It's kind of immune dysfunction, some kind of immune dysfunctions. Majority will resolve over time, more than 85%, only 5% become progressive. So this is an example of what I mentioned earlier, granulomatous lymphocytic interstitial lung disease associated with common variable immunodeficiency syndromes. In this particular case, we find loosely from granulomas and lots of lymphocytes, usually CD4 cells, and not much follicular expansion. So we don't see a lot of follicular expansion and a lot of CD4 cells. Looks like haplosplenomonitis. You can see a little bit of mosaic here also. But if you look at the type of cells, particularly in a patient with immunodeficiency, this is consistent with GLEAD. Now to summarize, I would briefly go over a simple algorithm. I hope that will capture what we have so far discussed a little bit. Now, histopathologically, when you say necrotizing granuloma, and if the granuloma is necrotizing versus non-necrotizing, that changes the direction. If it's a necrotizing granuloma, if there's a vasculitis, a necrotizing vasculitis, which is eosinophilic, then it's EGPA. But if it's not eosinophilic, it could be necrotizing sarcoid granulomatosis, or if it is not a sarcoid-like reactions, then you would call it granulomatous polyangiitis. Okay, so there's necrosis, what kind of cells are there? And if the necrosis look like sarcoid, you have a matured coalescent granuloma, and then necrosis of the vessels, that is necrotizing sarcoid granulomatosis. If on the other hand, that's not there, then think about GPA. In the real world situations, when you have that kind of findings and you see these nodules in the chest and the pathologists report that, we're going to still get thorough history, check urinalysis, proteinuria or not, hematuria or not, get the ANCA done, whether or not ANCA positive, negative, and the rest of the body, upper airway. If none of these things are present, and they will also get a PCR and fungal stain. If all of them are negative, then in the right context, we're going to call it necrotizing sarcoid granulomatosis. So that is, to a large extent, a diagnosis of exclusion. However, if you see palisading histiocytes, necrotizing vasculitis, that is not there, but the palisading histiocytes going around, rheumatoid arthritis, and some of the contexts which I shared with you earlier, think about rheumatoid nodules. You can also see that in inflammatory bowel disease. If the airway wall is destroyed, then that is bronchocentric granulomatosis, as you see in ABPA and asthma and other bronchiectasis. If the airway wall is not destroyed, it could be foreign body granuloma, aspiration pneumonia, etc. And if you don't have a foreign body, other features like, fat cells, forming macrophages, vegetable cells, cellulose, and other materials, then it can be infection. Now, the second major categories, as you see, there is no necrotizing granuloma, and they can have a feature of organizing pneumonia histopathologically. They can have a peribronchial inflammation along with organizing pneumonia. If that is present and they have a CD4 cell proliferations, then that is GLID, granulomatous lymphocytic interstitial lung disease. But there is no CD4 lymphoid proliferation, that is not there, but there's well-formed granuloma, then certainly hot tub lung, the case that you presented today. And if not, then hypersensitivity pneumonitis is in the differential. So you don't have CD4 proliferation, you don't have a well-formed granuloma, loosely formed granuloma, and the inflammation is going around the airway into the interstitium. That is the classic findings for HP. Now, if we don't see OP patterns and peribronchovascular inflammation, if it is lymphangitic or not, if it's following the line of lymphatic system and well-formed coalescent granuloma, matured granuloma, that is sarcoidosis or berylliosis. If it's not following the lymphatic distribution, then certainly it could be foreign body granuloma. If you see other features of foreign body granuloma, you call it foreign body granuloma. If not, for example, you don't have any features of aspirations, and not within the airway, it's the vasculocentric, then talc is top in the differential diagnosis. If on the other hand, you have lots of histiocytes, Langerhans cells, and you stain them with CD1A and S100 proteins, and they're positive, and that would be PLCH. I understand that is so much to take, but whatever you can retain, I guess that will be pretty good rehearsal to carry home with. I will not go through the details of this slide, except that I would like to mention some associated features that can help us direct our differential diagnosis or narrow our differential diagnosis. For example, if you see cavitations, then think about necrobiotic nodules, GPA, and sometimes lymphomatoid granulomatosis. If it's associated with pulmonary thromboembolism, then lymphomatoid granulomatosis or EGPA generally associated with pulmonary thromboembolism. If there's pulmonary edema and proliferation, again, eosinophilic granulomatosis polyangiitis. If there's a lot of medicinal adenopathy, then think about necrotizing sarcoidosis, even though lymphadenopathy is not very common in necrotizing sarcoidosis. If there's a clinical history of rheumatoid arthritis and IBD, then think about necrobiotic nodules. And if you see a lot of mucus infection, upper lung involvement, bronchiectasis, then bronchocentric granulomatosis. On the other side, if you see a lot of cyst sparing the costophrenic angle, and you have a stellate granuloma, a stellate appearance, cystic changes and nodules around the airway, that is PLCH. If patient has history of common variable immunodeficiency, almost always they have a splenomegaly and usually have lower lung bronchiectasis, that is the GLID. If you see a lot of fat density and consolidation, many times they can have esophageal dilatations, dependent lung, centrilobular nodules on tree and bud formations, that's classic of aspirations. And if there's very high attenuation nodules with pulmonary artery enlargement and right ventricular dilatations, think about possibility of talcosis. To end, so far what you have seen, what you have heard, is simply a little bit detailed iteration of the fact that the large variety of conditions ranging from infectious, immunological, idiopathic, genetic storage disease to several neoplastic disorder can present with granulomatous lung involvement. A comprehensive approach, including the detailed familial, environmental, drug, and occupational history, very good exam findings, appropriately chosen test results, and skills in the image and histopathological observations. And it's necessary that it's not just when you started basic science in school, when you're clinicians, we need to review and refresh our knowledge of pathology, because ultimately medicine is nothing but the clinical application of basic science. And in order for us to interact with the pathologist, to discuss the findings, to come up with clinical diagnosis, that is exceedingly important. And in many cases, we may need multidisciplinary approach, where we talk to the pathologist, radiologist, rheumatologist, discuss together, share the information, and try to come up with a final diagnosis. With that, I'd like to thank you very much for your patience and open the floor for any questions. This is actually a real picture of Cox's Bazar seashore.
Thank you, Dr. Habibur Rahman Lulu, for an excellent elaborate presentation. I now ask the audience for any question. If you can raise your hand and give us the question so that you can answer. And as it is now near about midnight in Bangladesh, there is no formal question. I am asking the panelists, expert panelists, to give their comments. I first invite Dr. S.M. Abdullah Al Mahmood to give his comment about today's presentation. Dr. S.M. Abdullah Al Mahmood.
Thank you. Thank you, Adnan Bhai, and all other panelists and our respected speaker, Dr. Habibur Rahman Lulu Bhai. His presentation is always elaborating, is very interesting. I participated many times in his lecture. Actually, it's a recapitulation of the basic or touch from the histological side of the pulmonology, and everything he discussed very nicely, like in board review course. So most of the thing he tried to discuss, I just like to enhance one with his point that those the asthma patient, bronchial asthma patient, they are developing the aspergillosis and bronchiectasis. These are the very common in relation with our bronchial asthma patient. We are daily in our practice we're seeing. And bronchiectasis, why the bronchiectasis develop is this type of patient, and aspergillosis is common bronchial asthma patient. From my thought, and I showed that this type of patient usually have the nose block and mouth breather in the night time. And those patients, those asthma mostly are allergic, and the response to the house dust mites in the night time when they sleep, their nose becomes blocked in a fan or AC, and there's mouth breathing. Our nose is like an air conditioner. The air through the nose is very clearly entered into our nose after filtering and others. But when they take mouth breathing, the repeated infection is common in asthmatic patient. And from the childhood, if you observe a patient, they take in different time their antibiotic and others. So from the childhood, due to negligence in the pediatrician. So this type of patient, repeated infection, and ultimately develop bronchiectasis. And also this type of patient, the aspergillosis, the fungal infection is very common. In our Bangladesh, we commonly encounter the granulomatous disease. The sarcoidosis is very commonly we face the pulmonologist here, and also other granulomatous disease. But sarcoidosis is in our context is common. Others, the rare thing that discussed by the Lulu Bhai is the hot tub lungs, and others. These are the not so we are in our I think not my experience, but I discussed very nicely. So all the things we can see that it's a very big lesson for us, and we will continue this type of session in future. So thanking you very much, and I also invite our other panelists to give their expert comment.
Thank you, Dr. S.M. Abdullah Mahmood, for a brief expert opinion. Now I invite Dr. Zakir Hussain Sarkar to give his comments about this presentation.
Assalamu alaikum.
Walaikum
Assalamu
salam.
alaikum. Thank you, Habib Rahman Bhai, for your really excellent presentation as always. I have learned a lot from your presentation. Though I attended some of your lectures before, and really it is very rich as always. Today's discussion was very elaborate, and you have covered the granulomatous disease of the lung very nicely, and very important points and how to diagnose granulomatous disease shortly. You have tried to make us understand, and I learned a lot. And what we face in our setting, mostly after tuberculosis, what Abdullah Mahmoud said, sarcoidosis, sometimes it's difficult to diagnose sarcoidosis in our context. And we go for bronchoscopy, and bronchoscopically what you said, that cobblestone appearance. If there is cobblestone, you do biopsies, but there are other features like erythema, nodular lesions, and granular lesions might be there, and those could be biopsied. And transbronchial biopsy we do here, though its yield is less than that of EVAS TVNA. We do EVAS TVNA very frequently. But my question to you is, if I go for bronchoscopy in a suspected case of sarcoidosis, and if I don't get any lesion within the airway, should I take biopsy from anywhere like carina or secondary carina? Thank you once again for your excellent presentation.
Thank you, Zakir Bhai, for your kind remarks. If you take a biopsy from the erythema nodosum, you may not see the classic granulomatous inflammation there, because it's a kind of dermal venulitis. It's like a paniculitis type of manifestations. But going back to your question, as you may know, this is often asked, even if we don't see much in the lung parenchyma, the CT scan does not show much. In that settings, if the patient has sarcoidosis, what percentage of them will show granulomatous inflammations? And the answer we find in the literature is between 60 to 80%. But they also recommend that you should take biopsy from at least 2 different segments and at least 8 samples. So it is kind of tied together. If you had 8 different samples and 2 different segments, multiple biopsies, even in those who do not have a lot of parenchymal disease, no significant parenchymal disease, they will end up having granulomatous inflammations, and the BAL will show a lot of lymphocytes, even though we read in the textbook that if you do CD4, CD8, a CD4, CD8 ratio of more than 4, angiotensin enzyme is not terribly helpful, but if it is very high, more than 100, in the right clinical context, that can tell us that this diagnosis is very, very likely. But the answer to your question is yes. Even in those cases, we take lung biopsy, transbronchial biopsy, and a very high percentage of them will have findings consistent with sarcoidosis. And the BL can be complementary in that regard. Now, if you're going in and you have a EBUS, then certainly sampling a lymph node should be done, especially in those who do not have much in the parenchyma. Because in case you miss the parenchyma, false negative, then the lymph node will give the answer.
Yeah, Habib Bhai, lymph node, mostly lymph node gives much answer, like 80 to 90% in case of EVAS TVNA. And in case of transbronchial lung biopsy, it is lower than that of it is 50 to 75%. But my question was that if the airway is normal, nothing is within the airway, can we take sample from the carina and secondary carina?
If there is a lymph node, because endobronchial
no, in the
sarcoidosis
airway.
is relatively rare, as you know, because most of the sarcoid patients you may not see. Otherwise, way less than 50% of the patients, when you do bronchoscopy, you'll see classical cobblestoning, endobronchial. So if we look for that, the sensitivity is going to be relatively low. But even in the absence of cobblestoning, if there's a lymph node and we suspect sarcoidosis or other differential diagnosis for that matter, certainly we're going to sample the lymph node. And going back to your question, in the absence of cobblestoning, transbronchial biopsy still is relevant. But in an individual situations where you may see, okay, getting a biopsy and potential complication and other things, you have the EBUS and you have expertise and skills, a good lymph node, just get it, and that can give the answer. You may want to avoid the transbronchial biopsy, that's fine. But that should not be decided by whether or not you see endobronchial cobblestoning. That's not very highly sensitive findings.
I just add in my observation. If in bronchoscopy, when you enter into the
I can't hear you. I can't hear. No, and it's Dr.
I
Adnan,
think
can you
he's
correct?
out. His internet connection is unstable.
হাবিব ভাই, আমি জানতে চাচ্ছিলাম আসলে যে লিম্ফ নোড থাকলে তো আমরা বায়োপসি নিব, আমরা টিবিএনএ করব।
we're seeing nothing, but we have to before. If earlier I have some that thus we already done like the AC video.
আবার চলে গেছে। জাকির ভাই, আমি বলছিলাম আপনার কথা কতটা বুঝতে পারি না, আপনি আবার বলেন দেখি।
আমি বলছি যে যখন আমি এয়ারওয়েতে যদি কোনো লিশন পাই, সেটা তো আমি স্যাম্পলিং করবই,
রাইট।
লিম্ফ নোড থাক বা না থাক, লিম্ফ নোড তো করবই থাকলে, বা লাং বায়োপসি যেটা ট্রান্সব্রঙ্কিয়াল সেটা যদি করার মতো হয় করব। কিন্তু বিফোর দ্যাট যেহেতু আমি এয়ারওয়েতে ঢুকছি, সেখানে তো আমি যদি কোনো লিশন পাই, সেটা ইন এডিশন টু দোজ স্যাম্পলিং আমি সেখান থেকে বায়োপসি নিব। যদি কবলস্টোন পাই, নোডুলার লিশন পাই, ইরেথেমা পাই, কোনো গ্র্যানুলার লিশন পাই, সেটা নিব আমি। কিন্তু আমার কোশ্চেনটা ছিল যদি কিছুই না থাকে, আমি লিম্ফ নোড আছে, in addition to sampling the lymph node, should I take any biopsy from the carina and secondary carina where there is no lesion?
I see. আপনি যেটা বলছেন যে আপনি ওখানকার যে মিউকাস এবং সাবমিউকাসে যেটা আছে এয়ারওয়ে, সেখান থেকে বায়োপসি নেবেন কিনা?
জি।
I would say that that is non-conventional. That is not necessarily standard practice. But taking into consideration the sarcoid pathophysiology, I guess the question can be posed in a slightly different way. You don't see cobblestoning, but you took good samples of mucosa and submucosa. How likely is that you will see granuloma? The answer is quite likely.
Yeah.
The yield can be pretty good, even though you're not seeing anything.
Yes.
Because you have a lymphatic distribution there.
Yeah. Thank you. Thank you very much.
Yeah.
Thank
it
you.
can be complementary.
Yeah. I got your answer. Thank you.
So finally, we have one panelist left, our research sir, Professor Dr. Asif Mustafa Mahmood. I now requesting Dr. Asif Mustafa Mahmood to give his expert opinion.
Thank you very much, Dr. Adnan. First of all, thanks to Aishapa for inviting me to join this wonderful discussion. And as usual, I was overwhelmed by Lulu Bhai's presentation, which I always am. And it always brings back, brushes up our memory, and also to makes brings a lot of information in a very succinct way for the participants. So coming back to what we talked about, I think that Dr. Habibur Rahman has made his point very clearly that this is a wide array of diseases, and with a proper approach, we need to clinch the diagnosis. And I'm very interested to see that in this very first, the clinical case he presented was a non-tuberculous mycobacterial infection. And as we deal with tuberculosis in our high burden country, in our settings, we often come across some cases where there's an overlap of sarcoidosis and tuberculosis. And very recently, I have the experience of handling 2 cases. And I would just like to emphasize on the point that even when we get such, because these are usually not sputum positive cases, these are cases which have lesions on the CT scan, and then the biopsy or the EBUS is done. And then it's very important, I would just like to point out that we should not miss the opportunity of going for a Zealand cell staining, and as well as for coming up with gene expert stain, as Dr. Habib Rahman has very rightly pointed out. And we have all the facilities in the country. I would just like to point out that this is going to be very helpful in diagnosing the cases. Thank you very much again for your kind presentation and discussion.
Thank you.
Thank you all participants for a very, very nice session. I think it is near about midnight, and if we permission from Habib Bhai and other panelists, I want to conclude the session now. Thank you all for
অনেক অনেক ধন্যবাদ, দোয়া করবেন, ভালো থাকবেন, ইনশাআল্লাহ আগামীতে দেখা হবে।
Thank you very much. ভালো থাকবেন।
Yes, Assalamualaikum everyone. Adnan, Zakir, and Mahmoud.
Yeah, assalamu alaikum. Assalamu alaikum, sir.
Assalam.